Hello, everyone. Welcome to the Telehealth in New Hampshire event here with the New Hampshire Tech Alliance. My name is Gary Sloper. I'm one of the board members here for the New Hampshire Tech Alliance, and I also work for a company called Macronet Services. And we're really excited today to talk about the telehealth initiatives that are going on here in the state. You're going to hear from some industry experts to talk a little bit about, what many of us are asking and maybe not aware of some of the initiatives. We're really excited to welcome two experts here, Jim Monahan, who's the founder of the New Hampshire Telehealth Alliance here in New Hampshire. He founded this organization in 2020, and it's really in response a lot due to the COVID-19 pandemic and many of the other things that are going on within the state. So we're excited to have Jim here, as well as Deb Fournier. She's the policy advisor for the New Hampshire Telehealth Alliance. And she brings a wealth of knowledge and is also has a background as being the senior associate for the UNH Institute for Health Policy. So we're really excited and fortunate to bring you this programming today. And there's a lot of great things that they want to talk about, everything from what is telehealth and what that means for New Hampshire, all the way down to some of the things that many folks we hear of throughout the state talking about broadband initiative and other things. So without further ado, I'd like to welcome both Deb and Jim to the stage. So come on up.
Great. Thanks, Gary, and we're very happy to be here. So as Gary mentioned, I'm Jim Monahan. I am, I guess, identified as the founder of the New Hampshire Telehealth Alliance. It started back in July. In a moment, we'll go through some initial background on the organization and things like that. But I'm joined by Deb Fournier, who is on the screen with you now. She is a policy the New Hampshire Telehealth Alliance. Has a strong background in healthcare. Deb and I first met when she worked for the Fiscal Policy Institute in New Hampshire and has a strong background there, but also was the Medicaid director for the state of New Hampshire. So we were very happy to trick her into working with us on this. So Deb is sharing her screen, and we're going to run through a few background slides, and then today, Kate, Deb and I will go back and forth. And we should start a drinking game here. There's multiple people in my office that work here named Kate, and I get nervous on webinars and I refer to Deb as Kate. So I'll stop that right now, but if it slips, I'll let you know. So just a quick background on the New Hampshire Telehealth Alliance. We're a membership-based organization and working to support those involved in developing a well-considered and robust telehealth industry in New Hampshire. Our members include healthcare providers, technology providers, and developers, advocacy and consumer organizations, and it's sort of a nice diverse group of people who are all involved in the industry one way or the other. What we do primarily is help the people that are members better understand what's going on in the legislative and regulatory process, both at the state and the federal level, so that they can advocate for specific policies, and they can also begin to adjust their business practices to conform with how things have changed and will be changing. We'll go through some of that today. Not to do too big a sales job on you here, but the benefits of membership are outlined in this slide here. You can also find us at New Hampshire Telehealth .com. I probably got that address wrong, but you'll be able to find it. And so we think we have probably at least an hour today, so we hope you all have time to stick with us, but we want to be efficient in the information we run through with you before we move into questions and answers. We're going to offer a state of the policy in New Hampshire today, address emerging public policy issues around the public health emergency, what to expect next as the public health emergencies wind down, and then touch a little bit on the really significant resources for telehealth and broadband, which are included in the American Rescue Plan Act. Last thing I'll touch on for background, in addition to being the founder of the New Hampshire Telehealth Alliance, I'm also the president of the DuPont Group. We are a government affairs and communications business in Concord, New Hampshire. And so the lens I bring to this is very much focused on public policy at the state and somewhat the federal level. I gave you a little bit of background on Deb, and I'm sure when she jumps in the next slide, she'll add to that. Her background, in addition to understanding what goes on from a public policy perspective, also has worked very closely with providers and practice groups, and I think understands how a lot of this public policy gets translated into the business of healthcare, if you don't mind me oversimplifying it, Deb. So with that, I'm going to let Deb jump in around to the next two slides to kind of orient us to what we're talking about today, and then she'll bleed into what we learned through the COVID emergencies and the telehealth experience.
Thanks, Jim. Thanks, everyone, for having us today. I am Deb Fournier, the policy advisor for New Hampshire Telehealth Alliance, and I am guilty of being a former Medicaid director for the great Granite State. And we're only going to talk a little bit about Medicaid today. It's just one of many players in the telehealth field. But I just want to start at the very basics. There's a lot of terms getting thrown around right now about telehealth and telemedicine. And so for the purposes of today's discussion, we're going to approach telehealth the following: that it's the use of electronic information and technology to support distanced clinical care. So telehealth means a lot of different things to a lot of different stakeholders, and there's subcategories of technology within this term. Some are very old and some are relatively new. But what I want you to remember is that this is an all-encompassing omnibus term. That means we are using technology to support clinical health care virtually. Now, the primary pathways that we do that are through these four mechanisms. And there won't be a quiz, although we should have included a poll, Jim, to see if people are following along. So these four categories are remote patient monitoring, live video, communication technology-based communication, and store and forward. So remote patient monitoring, for most intents purposes, is using digital technology to collect medical and other forms of health data in one location and then transmit it electronically so that the information is securely transmitted to another healthcare provider. So at this stage, remote patient monitoring can be things like a tablet that is used to download the vitals of a patient, and then those vitals are transmitted to a nurse practitioner who can take whatever necessary steps are indicated to continue caring for that patient. Live video is essentially a two-way interaction between a patient and a provider using audiovisual technology. Often in the telehealth world, you'll hear references to the time in which something is provided, whether it's synchronous or asynchronous. So this is referred to as real-time or synchronous connection between provider and patient. And it is on occasion seen as the substitute for an in-person encounter where appropriate. Remote communication technology based communication is largely connecting by mobile phone. And store and forward are technologies that allow for the electronic transmission of medical information, like digital images, documents, or videos through a secure transmission line. This is often how providers might facilitate consults with one another, is through a store and forward mechanism.
And Deb, real quick, look, I got a question in on that. I think somebody wanted to ask, would that be considered Follow My Health? It sounds like it's a mobile app that you could do some of that. Is that something similar?
I'm not familiar with that platform, but it's entirely possible.
Okay, great.
So the state of things with respect to telehealth is that it's actually been around for a very long time, but prior to last year was unused for the most part. Medicare is one of the largest payers in the country, and it started paying for some telehealth services about 20 years ago in 2001. But it was really restricted. The patient, in order to qualify for the service to be provided via telehealth, had to live in a region that was designated a rural region of the country. There were very specific and limited constellation of services that Medicare would reimburse for when delivered via telehealth. And what seems unimaginable now, really, is that the patient had to present him or herself at a doctor's office, at a provider's office, in order to have the telehealth visit, the telehealth interaction. So basically, it was there, but no one really used it. And then we all experienced 2020, and within a period of a few short months, COVID-19 accelerated the adoption and use of telehealth, probably made as much progress in 20 years. We made as much progress in 5 months as we made in 20 years with respect to this modality. And just throw some data up here to prove my point. This is telemedicine utilization prior to COVID and after the start of COVID. And the charts go from January of 2020 to July, so it's not the complete picture, but you get the point. If you dig a little deeper, consistent with most of the other healthcare utilization information that we have, racial and ethnic income disparities continue in the use of telehealth. If you use telehealth, you are more likely to use it if you have a higher income level, if you are white, and if you are younger. So what facilitated this on a policy level was there were, as I'm sure you all remember, a number of COVID relief bills that were enacted in 2020. And in March of 2020, the major restrictions in Medicare were lifted, which led the way for restrictions to be lifted in commercial products and to a certain extent in Medicaid also. So what happened was patients no longer had to go to present themselves to a provider's office. They could receive a service via telehealth at home. Telehealth services were required to be reimbursed at the same rate or no less than the same service would be paid for if it were provided in person. The privacy regulations that govern how you transmit confidential information were relaxed so that people could use their home phones and the applications that they had readily available to them. Providers were allowed to practice across state lines when they had an existing client in another state and they could provide them services via telehealth. Most of the restrictions around licensure, both at the Medicare level and at the state level, were waived. And then Medicare also said, and you don't have to charge anybody co-payments for your telehealth services. And as we saw, if I can just go back a slide, as we saw up here, actually, I'm sorry, these slides don't show this, but as you can see, there's nearly no telehealth prior to the pandemic starting, and then there's dramatic increase. Telehealth in many respects backfilled revenue for healthcare by ensuring that patients could see their providers and that providers could continue their businesses, even though, at least in New Hampshire, we were at a safer at home order, which encouraged nearly everyone to stop what they were doing and stay home. So what's important about this prior slide here is that all of those flexibilities at the federal level are temporary. They only last as long as the federally designated public health emergency lasts. It's been renewed multiple times. The most recent renewal was in April, and it is currently set to expire on July 14th. The Biden administration has made public overtures indicating that it didn't think that the public health emergency would be ended before the end of 2021. However, they are not bound by that, and it's politics, anything can happen. But all of those waivers at the federal level with respect to Medicare are temporary and without additional congressional action will end when the public health emergency declaration expires. So I'm going to turn it back over to Jim so that he can talk to you about what the state level reaction with respect to the policy front was with respect to telehealth and COVID-19. Jim?
Yeah, thanks, Deb. Yeah, so things accelerated very rapidly from March 1st through the first 2 weeks of March, as New Hampshire knew that there was a national public health emergency on the way. Honestly, it seems like a lifetime ago, but it was only 13 months ago that we're all experiencing this, and the things changed very rapidly as Deb observed, and providers and consumers had to respond to it. But under New Hampshire state law, the governor of New Hampshire can, by executive order, declare a state of emergency. And once he's declared that state of emergency, is empowered to issue emergency orders for how the state would operate, things that would normally be done through an act of the legislature. I think to date, the governor has issued about 75 various executive orders, which range from mask wearing to telehealth, as identified here. You'll notice executive order number 8 was one of the early executive orders that was enacted, and it began almost immediately in March. It mirrored in large measure what was provided for at the national level with the suspension of requirements at Health and Human Services and CMS. And while there's a lot covered on it, the major components were that providers could provide telehealth coverage. Oh, I'm sorry, Deb, thank you for.
Oh, sorry.
No, that's okay. Yeah, why don't you just go back a slide so we can say in that one, then we'll move into it. Yeah. So the major components were that all providers could provide care through telehealth. Obviously, this is where you would, hospitals, for example, didn't do open heart surgery by telehealth, but most of what would have been an outpatient visit could take place through telehealth. Provided the mechanics for that. It provided reimbursement at parity, meaning just as with the federal orders, reimbursement to the provider from the payers would be at parity or no less than if it were an in-person provision of service. And a big deal, which continues to be an area of dispute in New Hampshire, is that telehealth could be provided by audio only, which really meant a telephone connection. That was very much focused on the fact that we have such poor broadband coverage in New Hampshire. We did not want to leave folks that didn't have access to broadband, whether it be the equipment in their home or internet connection, that still needed healthcare. We saw this in the behavioral health space. It was a huge deal, and there are also people that are experiencing homelessness that were able to get access to mobile telephones in order to continue their care without having to come into the office, which is really what was driving it. Because if there was a stay-at-home order in place, we still needed people to get the healthcare that they need, and the providers, we didn't want to bankrupt all the providers for it. So that emergency order under state law can last for 21 days, but the governor has the authority to extend as long as the overriding executive order is in place. So as Deb observed, that's one. It has been renewed nearly 20 times. And the early indication was that the governor intends to continue to extend that executive order through the end of the year. But we're not exactly sure that that's going to happen now because there is a general sense that because of the vaccination programs going well and the other data that they use to track the pandemic are dropping off, there is political pressure and policy reasons for those executive orders to begin to roll off. And the governor did announce last week that he would begin to allow a lot of those 75 or so emergency orders expire when the 21 days run out. I think that's probably not going to happen with Executive Order 8, but we don't have a lot of clarity in that right now. But that should be okay because I think I mentioned before, we do a lot of government affairs work, and so we do represent a lot of healthcare providers ranging. They include mental health centers, community health centers, some of the largest health systems in the state. And so, although the legislature had suspended its in-person last March, they were meeting virtually. A group of legislators, primarily in the Senate, but also with some support from the House, moved forward to enact permanent legislation around any event. On July 21st, and not to oversimplify things, but it is almost as simple that virtually everything that was covered in the emergency order includes which is and so today with regard to overlapping emergency order authorization for the provision of telehealth services and a statutory provision that's in place and will dictate both the statutory and regulatory structure in the event that the emergency order expires. So if we can move on to the next slide. Maybe lost Deb. Yeah, okay. You know, as I mentioned, if we, yeah, you can go ahead and move on to the next slide, Kate. Another important thing which we'll talk about a couple times today is that what includes working those who argue that we shouldn't do that because we didn't want to be truly for its failure. We be in a position where switched on and off, so that we might not know what the provision of our care was going to be month to month. It was important that it be and so the legislation has to include the creation of a pretty robust study commission that includes 14 representatives that include public health officials, providers, and legislators who are busy studying what's going on with telehealth services so that they can make adjustments and changes in future legislation. And so let's move on to the next slide. Great. So as we move, so that's kind of the state of things from both what happened, what emerged through the pandemic, which got us to the state of things now. And so what Kate and I and Deb and I want to run through now is a little bit of a teaser about what to expect at the federal and the state level in the months to come.
So at the federal level, as I mentioned, the current authorities in Medicare are predicated on the public health emergency declaration at the federal level, which currently runs, as I said, through July 14th. And there have been public indications by the current administration that they will continue it until the end of the year. However, to Jim's point earlier that the vaccination programs are going well, it's possible that the public health emergency at the federal level could be ended earlier. We have no indications one way or the other, but all to say, there is an end when the public health emergency expires at the federal level. There are some final rules, some changes in Medicare that were made permanent by some of the COVID relief bills. The most notable one for telehealth and healthcare in particular is that Medicare gave permanent authority to cover mental health services via telehealth in its statute. And so that can that will survive the public health emergency declaration. However, they didn't permanently erase face-to-face requirements or originating site requirements for Medicare visits. So it still has some limitations, but the coverage for mental health services is permanent, which is great. Congress seems pretty concerned and interested in this issue and is aware of the lagging federal authorities. And there are no fewer than 17 bills that in some way deal with telehealth on Capitol Hill right now. One that our own congressional delegation is involved in is the Connect Act. It has a House counterpart as well. And that vehicle essentially gives the Secretary of Health and Human Services the permanent authority to continue to waive the authorities that are current, or in other words, gives the Secretary permanent authority to create the flexibilities that the healthcare industry is currently enjoying via telehealth. Those 17 legislative vehicles are bipartisan. There is not one party represented more than the other in their sponsorship. And some observers are pretty bullish that whether it's a standalone vehicle or the language in one of these bills gets attached, if there is another big package that comes out of Congress this year, that something will get enacted to continue these flexibilities at the federal level. Again, it's politics, so anything can happen. I want to ask Jim to step in and talk a little bit about what we've seen on the New Hampshire developments and what we expect to see over the next few months.
Yep. Yeah, so in New Hampshire, I think things are relatively quiet right now, but we'll get quite busy in the second half of 2021. Legislation was filed in January. It was House Bill 602, which had potential rollbacks. In particular, it proposed to eliminate the audio-only provisioning of telehealth, and also left the question of parity up to the payer to decide what they should pay the provider with regard to the telehealth activity. As you all know, the New Hampshire legislature is mostly virtual these days, and so we weren't sure what was going to happen when this bill had a public hearing. But the Health and Human Services Committee had a public hearing, I think, the first week of February in this bill, and had nearly 3,000 people sign up in opposition to the bill and more than 100 people testify against it. And they had 8 people testify to support it. So there was an overwhelming public response in opposition to the changes, to changing the state of things with telehealth. People seemed to be to like it and didn't want to walk away from it. And I think ultimately, and we'll talk about this perhaps when we get into more of an open dialogue, is that the general consensus seems to be that we don't know exactly where we're going to settle on telehealth, but we're not going back. Both consumers and providers have adapted. We'll probably never have 80% of the activity taking place as telehealth as we did back in May and June, but it's here to stay. As we've mentioned before, we do need to be prepared for Emergency Order 8 to wind down. There are some minor components of the legislation which are not covered, that are in the executive order, which are not covered in the emergency order, which may be addressed as part of the work of the Telehealth Commission. But another important part of this, although I tend to represent providers and consumers, is making sure that the payer perspective be inserted into the public policy dialogue. And that is a whole range of things. The payers need to be comfortable they're not taking too much of a business risk, and they also have to set health insurance rates for their activities. So they'll have lots of questions about utilization and outcomes and how that might affect what they will advocate for reimbursing or not. The current state of things is for most people, folks in New Hampshire, their payers cover telehealth, but it's important to understand that neither the federal changes or the state changes impacts self-insured plans or ERISA plans. Those primarily are plans that large employers use, where they hire a third-party administrator to come in and make payments, but the underwriting risk is assumed by the business. And by our calculations, it fluctuates year to year, but it's anywhere from 20 to 24% of New Hampshire citizens are covered by ERISA plans, which are not at all regulated by either the federal statute, the emergency order, or the statutory changes that Deb and I have talked about. To date, most of the ERISA plans in New Hampshire have just provided the same benefit that exists under Medicaid, Medicare, or the commercial plans. But I don't think any of us should be surprised that when the emergency order unwinds, that some of these ERISA plans will no longer reimburse or allow for telehealth in the same way that they had. And that's something that we all want to watch closely to see how the ERISA plans react. They've been a little quiet. Deb and I have tried to tease it out from them, and it's, and question is easier asked than answered, because a number of the ERISA plans, they just hire Anthem, for example, to handle the payments, and rather than creating something new for a large employer, they might just mimic what exists in a fully insured plan. And so those may change. We don't know, but I wouldn't be surprised beginning at some point in the second half of 2021, those of you who are insured by ERISA plans may find that they're not encouraging you or paying your provider for a telehealth visit. So stay tuned on that. And then we would anticipate that when the legislature returns their focus on House Bill 602 this fall, I should have mentioned the bill had lots of opposition, and so the legislature decided to put it on hold and take no final action on it. But they do need to take final action in the committee by early November. So I would imagine the payers will probably have some suggestions to changes to that. So that's what we're readying for at the New Hampshire Telehealth Alliance. So, okay, I don't know, Deb, if you've got the next slide or not.
I do.
Great.
So we wanted to talk a little bit with you about the American Rescue Plan Act and what that may or may not have to do with telehealth. So just really quickly there, none of the federal Medicare authorities that I discussed earlier were made permanent by the American Rescue Plan Act, but the American Rescue Plan Act did include funding to support telehealth in a variety of ways. They're listed here, and these reflect the places where telehealth has been vital. They provided some emergency grants for rural healthcare. The Department of Agriculture has a large rural support portfolio, and rural healthcare falls in there. And so they are providing funds so that facilities can improve and increase their telehealth capabilities, including their underlying IT systems. There is funding for telehealth infrastructure for Indian health, community-based funding for local behavioral health needs. There's funds being provided there. Telehealth is flourishing in the behavioral health space. Mental health providers continue to see a robust utilization of telehealth, even as the stay-at-home or safer-at-home orders are receding and more people are becoming vaccinated. There are a lot of benefits to having telehealth available in the behavioral health space, and the American Rescue Plan Act reflects that by providing some additional funds for that space. And then also for home visiting, to make sure that we are optimizing the technology that we do have and keeping people safe at home at the same time. And the last thing with respect to the American Rescue Plan Act is broadband. There is a significant amount of broadband funding in the ARPA. As Jim mentioned, this is important and connected to the ability of providers right now to provide telehealth services via audio only, so only by phone. And this is especially important in a state like New Hampshire that has rural regions, that has challenging topography like the mountains, and sparsely populated places where it hasn't made a lot of business sense for internet service providers to expand their businesses and provide direct to home broadband service. So, and there were public comments recently that broadband service is now considered akin to infrastructure the way highways and water systems are. And so that's reflected in ARPA. There's $7 billion coming to schools and libraries to help them purchase connected devices for their patrons and their students to use not at those facilities, but to use remotely. There's $10 billion for capital investments across the country. And then there are hundreds of millions of dollars, more than $900 million coming to New Hampshire alone for state and local recovery dollars. And broadband funding is one of the items identified in the legislation as being an eligible use of that funding. So I'm going to stop there, though, on the broadband funding and ask Jim to talk about there's more activity other than the American Rescue Plan Act around broadband happening at the state level. Jim, do you want to talk about that?
Yeah, as Deb mentioned, the amount of support for broadband deployment in the American Rescue Plan is significant. And I don't want to oversimplify it, but I do think that when we get to 3 years from now, if we haven't dramatically increased, I mean by a lot, broadband internet connectivity for New Hampshire citizens, it won't be because we didn't have enough money. Well, I'll talk about some of the challenges, though, but as Deb mentioned, there are specific carve-outs in the infrastructure dollars that state and local governments in New Hampshire received. They specifically call out water, sewer, and broadband as infrastructure projects which should be deemed ready to go. That you're not going to have to prove that there was some sort of COVID-related activity or harm created by the pandemic to justify the spending there. They want the dollars spent there, and that's even before the Congress passes an infrastructure bill, which will probably be in the early fall. Some of the things to deal with, though, in that is how is that money going to be deployed into whom? The rationale for or the justification or the push for broadband is not only telehealth related. New Hampshire has, for the last few years, struggled to figure out a way to deploy broadband, mostly from an economic development perspective, but also increasingly from education and a little bit from telehealth. Part of what we're doing with the Telehealth Alliance is trying to get healthcare providers and advocates a seat at that table, and they seem very welcoming at the state level. A few things to keep in mind. Now, this is my lens. Everything's a piece of legislation, but in 2020, before the pandemic even started, House Bill 1111 passed, which allows for the creation of communications districts. And these are like TIFs, but they don't have to be in a single community. It can be a district within a community, or you combine multiple communities. And the critical component of the communications district is it authorizes bonding for broadband and communications investments. The tricky part of broadband deployment has been that in rural parts of the state where there's not dense populations, the justification of a private investment in broadband, whether that be through cable or fiber or however it may be, and there's lots of, and you all know better than I, there's lots of different ways to get a high-speed connection to somebody. It's hard to justify that investment if you don't have the density to justify it. So many communities have said, okay, fine, if the broadband providers aren't going to provide it. We'll pay for it with public dollars. And went to legislature, created the authority to create communications districts for that, exactly that bonding authority. And a number of communities have started down that path. Bristol, New Hampshire has been held out as the prime example of how you can get that done. But even there, they had to cobble together lots of different funding sources to raise the money to begin the process of deploying broadband. So that regulatory structure exists and may or may not be used for this deployment. Meanwhile, the state government is in the process of passing Senate Bill 85. This is going to set up a state matching program. And so what I expect will happen is some meaningful portion of the state's rescue dollars, infrastructure dollars, will be put into a pool of funds. And then either local municipalities or communications districts can draw in those funds by matching local dollars, which can be rescue fund dollars or bonded dollars, with the state matching fund to deploy it. So those are two good mechanisms, but really what they demonstrate is that we're likely to have a very balkanized system in New Hampshire when it comes to deploying broadband. There'll be certain standards that have to be met, and I don't think anyone's yet pushing for what would be defined as universal broadband access, but a lot will get done. But one of the challenges is that there's no right now baked into the structure of state government a formal broadband czar or one place in state government that's in charge of it. Really, what the state has been doing so far is giving local communities the tools that they need to do their own broadband. And I think, right or wrong, it's more likely over the next 2 or 3 years to be done that way rather than having one statewide plan. It gets to the point where, I don't know, 6 weeks ago maybe, Deb and I started trying to get a sense of the mapping of broadband and found out that the state had a program, but it ran out of money in 2015. And so some of the mapping that's being used is still based upon that work from 6 years ago. Again, that just reinforced that at the state level, it doesn't seem, other than Deb Fournier, nobody's running the show. That doesn't mean it's not necessarily going to get done. We run school districts that way. We have a town meeting forum with government. You can drive from one side of the state to the other on paved roads. Even when we do things on a town by town or localized level, it gets done. It just strikes me that that's what we need to be prepared for, both on the funding and the infrastructure investment in broadband. That's what we know that's going on, kind of the state of telehealth in New Hampshire through our lenses. I'm sure the people on the meeting have their own lenses looking through. So, Gary, I'm going to throw it back to you to answer any questions you or others might have. And hopefully, I understand my audio was not great, so hopefully that's improved.
Yeah, you sound well now. So thank you for that, and thank you for that. It was very informative and a great overview. I guess for the audience, just a reminder: if you have any questions, to drop them into the chat. We'd certainly like to get those asked here and answered back. One question that did come in to me, it looks like it was more, kind of a high level question, the broadband initiative. So the question was, outside of the broadband initiative, is there any foresight in the future where the government may allow a home user to utilize their flexible spending account to potentially pay for their broadband connection if the industry started to move towards more telehealth? So I know that that's probably not something that the Fed has probably looked at yet, but I'm not sure if that has come up on any conversations that you've had.
So I'll take this first and then see what Jim's thoughts are. I think that's a brilliant idea, allowing someone to use their health savings to contribute toward the cost of their service. And Jim might have a more Jetsons-oriented answer. But what I wanted to say is that there are programs through the Federal Communications Commission that helps people to get discounts on their broadband service if they meet certain eligibility requirements, and they agree to get service from a particular provider. There's probably 20 or 25 providers in New Hampshire that are in that program. It actually just opened today to consumers. And so there certainly are folks in the federal policymaking circles that are thinking about how do you help people access those services. But those are mostly lower income people who qualify for free or reduced lunch, Medicaid, not necessarily folks that have access to things like HSAs or FSAs.
Sure.
I love that thinking is starting to percolate. Jim, I don't know if you had an additional thought about that.
I would make the same observation with you that for low and moderate income folks that take advantage of healthcare programs, there is some coverage for that. And somewhat on a temporary basis, but the managed care companies in Hampshire, which run the Medicaid program, were actually providing folks with cell phones and minutes during the pandemic to actually pay for their care. So it's a great idea, and this is ultimately a determination the Internal Revenue Service has to make, or the U.S. Senate Finance Committee as they develop legislation. And so we've got an active dialogue going with Senator Hassan, who's on the Senate Finance Committee, which would direct some of this. So I made a note of this, but if any of you talk to Senator Hassan before I do, it's a good suggestion to make.
Great. Another question came in. Looks like it's around private technology companies. So have you seen anything in the state that would award private technology companies to help with some sort of matching capabilities or other incentives if they were to move into these areas where, think of, more rural and broadband capabilities that are starting to come about? Is there anything that they can do to equally match, or anything that has been discussed there just from the private sector?
Jim, I'm going to let you go.
Yeah. So a few things. I don't know if I'm exactly answering the question, but we can get some follow-up if we want. So under the communications districts, which I identified, those districts can receive funds from lots of different sources. They can have a broadband bake sale if they want to raise the funds for this. So I do think it allows for private participation. There's a little sensitivity around the communications districts using public funds to compete with private providers. That's primarily, the Comcast and the
Sure.
Consolidated. And the way the structure was set up is that if a community is going to deploy, my words, not exactly what's in it, they would need to give the incumbent provider kind of a right of first refusal for the deployment. So that's kind of on the activity to the door. The other thing that we're exploring is when it comes to spending broadband dollars, what does that mean? Is that just the fiber or the cable, or does it also mean making sure that there's universal access, there's equity access to the equipment that's needed for people to participate either at in education or healthcare? And that gets in a little bit to what we're seeing already emerging. We see it in the healthcare industry, where there's private providers and people coming up with GWIS mechanisms to monitor healthcare in the home. We're seeing a lot of people competing to do that for in the long-term care space. So before somebody goes into a nursing home, can we make their house into a smart house? Sorry if I'm oversimplifying this for that. So that's where we see some of that activity. And then what we don't see, and we understand there's a lot of activity taking this place, is this around electronic medical records and provider-to-provider activity. The GWIS stuff that lets a CAT scan be conducted in Berlin, New Hampshire, but read by a professional in Concord or Boston or Johns Hopkins and things like that. So there's a lot of that non-consumer activity that we're seeing a significant amount of entrepreneurial activity taking place.
Yeah, and that's a good point. I would imagine, getting back to your earlier point on just the educational piece and getting more access, I wonder if that also, there'd have to be another review that kind of looks at how E-rate is done a lot for the schools when it comes to that type of access. And maybe there's some forgiveness if, providers are able to come in to help utilize some of the schools to help fund that and other things. And the reason why I bring that up is it actually ties into another question here that came in. One of the participants asked, do you expect that there'd be funding to help users with those devices. So again, in the school, for laptops and others, because if we saw during, when the pandemic hit, everybody, that traditionally either had their jobs that were always in the classroom for the last 20, 30 years, immediately had to go out of the classroom and figure out how to do their livelihood from the home. But the same thing with the students and the parents, now trying to buy these devices, and it was scooped up, similar to what we saw with some of the personal products out there in the industry. So I didn't know if that had come up at all, if there would be some sort of funding, and maybe that falls into some of the lower income rates as well, that maybe they automatically qualify, but maybe not. Maybe there'll be something else that you're seeing.
So there's yes to both. So
Okay.
The emergency broadband benefit that is for lower income folks to help them get discounts on their service. Some of those providers also will help people access devices, connected devices, and there's certain parameters. They have to contribute a certain amount of dollars, and the customer has to contribute, a certain amount of dollars. Also, the money going to the schools and libraries, the $7 billion, that is to provide connected devices.
Okay.
And it is for the patrons of schools and libraries. And the guidance was very clear that they want to prioritize laptops and tablets, that they will not be paying for desktop computers or for phones, and that they want these devices to be used remotely. They don't want to buy school computers for school. They want to buy devices for students or for library patrons. And so, rather indirectly, I think there are going to be vehicles for students and families and library patrons to get a hold of devices through these federal programs. And they won't be able to restrict them only to library use or only for educational use. It's simply not possible. And so may indirectly end up contributing to the provision of telehealth. That way, in fact, there are a few emerging projects in New Hampshire where the library has been the place that provided the Wi-Fi hotspot or a private room with a connection where a patron could come in and have a telehealth visit. And so this may be some reverse engineering that will end up encouraging proliferation of more of those types of services by libraries, but there's no organized effort beyond this very large pot of money.
Yeah, and it's very siloed. Deb, I think you agree with me that there's education money, E-rate money, SSC money, there'll be telehealth money. But at least what I read in some of the E-rate and schools and libraries stuff is that there's an acknowledgement that putting an educational device in the home is going to help for economic development and telehealth. So they're not only do they recognize, they're encouraging, I guess, that these devices be used for more than just education.
Right.
Great. Well, this was excellent. I think we've answered all the questions. I appreciate your time. Where should people reach out to find out more information around your initiatives within Telehealth in New Hampshire? Is there a website and other things that you can share at the end of this?
Mm-hmm. Yep. So
Great.
the easiest way is to Google New Hampshire Telehealth Alliance, and that'll direct you to our website. There's part of it that's public.
Thank you, Josh just put it in the chat. Thank you.
Great.
Oh, perfect.
Right. So you see it there. And one of the things you'll notice is that we do a monthly webinar. Our next one is this coming Monday, and it's actually very focused on the payer perspective, which I spoke about earlier. So certainly what we're seeing is that most of what we've been doing through the Telehealth Alliance has been through that public policy lens, but we really, in the second half of 2021, really want to pull in the technology voices into this as well. I want to know about all the gee whiz stuff the Tech Alliance is developing in this space, and so we really do want to do an in-person conference on all this. We're just waiting to figure out better what the rules of the road are, and then certainly we have been pestering Julie Demers a lot about making sure that what we're learning, that we figure out a way to communicate with the Alliance. So if I haven't thanked yet, I don't think I have. I do want to thank for not only facilitating this, but we've had an ongoing dialogue about what's taking place in this arena in the public policy space. So, and then Josh walked Deb and I through your webinar process, and Gary, thank you for
Yeah, I appreciate it. Thank you so much. Appreciate everybody joining today. We'll get everything posted. If you have any other follow-ups, let us know, and we'll end the session, and people can head back to the tables.